Urine stress incontinence is involuntary leakage of the urine during the activities that increases the intra-abdominal pressure such as coughing, sneezing, laughing, or exercising. It occurs due to the urethral sphincter dysfunction of the weakened pelvic floor muscles. Pregnancy and the vaginal delivery, pelvic floor damage, menopause, estrogen deficiency reduce the urethral support. Obesity, increased intra-abdominal pressure, chronic cough, COPD, smoking, heavy lifting, high impact sports, pelvic surgery, hysterectomy. Urethral hypermobility, weakening of the pubourethral ligament and the pelvic floor muscles leads to the loss of the urethral support, leakage with the pressure. Interstitial sphincter deficiency, this fails to close properly, causing the urine leakage even with the minimal exertion. Urine leakage with the coughing, sneezing, laughing and excess, no urge to urinate before leakage, distinguishes from the urge incontinence. Persons with the high impact activities, no nocturia or the urgency, unlike the overactive bladder. Clinical history plus a physical examination, cough stress test, leakage with the coughing or the Valsalva maneuver. Q-tip test greater than 30% of the movement of the urethra suggests urethral hypermobility. Urodynamic studies lesser than urethral closure pressure, normal bladder function, no detriment or overactivity. Post-void residual urine volume normal. Treatment: conservative management, first line or the mild case. Pelvic floor exercise, strengthen the pelvic muscles, Kegels. Weight loss if obese. Bladder training, timed voiding. Necessary or the vaginal insert for the urethral support. Pharmacologic therapy, topical estrogen for the postmenopausal women. Relaxin increases the urethral sphincter tone. Surgical treatment for the severe cases, mild urethral sling, mass procedure gold standard. Birch colposuspension for the urethral hypermobility and the urethral bulking agents for the IST temporary effect. JSI is the involuntary leakage of the urine with the activities that increases the intra-abdominal pressure caused by the urethral hypermobility, intrinsic high sphincter deficiency. Common risk factors like the pregnancy, vaginal delivery, menopause, and obesity. No urgency of the nocturia distinguishes from the urge incontinence. Diagnosis like clinical exam, cough stress test, and the Q-tip test and the urodynamic studies. Kegel exercise or the first line treatment for the mild cases. Mild urethral sling surgery is a gold standard treatment for the severe cases. Relaxin can be used to increase the sphincter tone. PCD or the vaginal inserts provide a temporary relief by supporting the urethra.